with a clinician. So without further ado, how do we cope with this extreme, and how can we still help our IBD patient? That will be Dr. White, and he's an entertainer. So I really love him. From day one, I'm here, and hopefully, this, discussion, I think, partly because it's not just a presentation, will be really enjoyable, and he will help to share also, I guess, our trouble and our, struggle, with how we try to, make things work, as well as, what is the information and, the real data around, the IBD and COVID. And, you have to know he's not just a clinician, okay? So he's actually an entertainer, an art person. I think he has more, master's degrees than what you can count on one hand. If I'm not mistaken, and he loves photography, art, once again, so not just IBD. So I guess he will give us really the different angles of how we do today. So I think that was, the run-in. And Gary, please share your screen and, teach us a little bit about, today and IBD.
Thank you, Peter.
I'm just going to encourage everyone, or maybe Dr. Wild, if you can do it, that everyone's on mute if they're not speaking. Because I see, there's a few people that are.
Yeah, for housekeeping rule, you can send actually, messages to all. Dr. White is the host, so he will see that, and then he can, cherry pick a little bit, important, remarks or questions, and also put that into the, discussion or the presentation. Thank you.
Thank you.
Thank you. So I'm going to try the share screen. And can everybody see that?
No.
No, not yet. You didn't share.
Not yet.
You have to choose. You have to choose which screen to share, Gary.
Can you see it now?
Still not.
Are we able to see it?
No.
Jeez.
Gary, speak
Now.
There we go.
Now. Yep.
Oh.
Great.
Okay, so we got it?
Yeah.
Yep.
Okay, so I entitled the talk Living with IBD During COVID. And the whole goal of the talk this evening is
No,
to...
it shut
Gary,
again.
it stopped.
It stopped.
But it worked. I mean,
look, if you just open up the PPT, don't present because the presentation will freeze it. Just put it, on the slide mode within the PowerPoint, and then it's okay. If you want to present, then it will stop sharing.
So I'm on slideshow.
Yeah, that is what is not sharing. Just, just go in the program and don't slideshow, but just to go over the slides.
we'll get there.
You see that?
Not yet. If you send it to me, I share if you want, Gary.
Yeah. Yeah.
Although I have, you want me to hear 1 second?
You can share as well.
I'm going to try. And then Dr. Wild, you can just tell me
Sure.
which ones. Can you guys see that?
Yep.
Yeah.
Okay. I'm going to be the person in the background here.
That's better. Good.
Go for it. You tell me when, okay?
Okay. All right, next slide. Good. So our whole focus of our discussion this evening and dialogue will be related to health-related quality of life in IBD, but as it relates specifically to the COVID crisis. And we see the quality of life, that there are multiple domains that influence it. There's the disease activity, there's quality of care, quality of life, coping, stressful life events, the psychological status of the individual, and social support. And the majority of the meta-analyses have shown that disease activity itself accounts for about 1/3 of quality of life, and the psychosocial factors contribute to about the remaining 2/3. And as Dr. Lakatos alluded to, quality of care has become an increasingly important determinant of quality of life. And the establishment of the McGill IBD Clinic and our Rapid Access Clinic was almost prophetic in the sense that it provided the underpinnings and framework to really allow for rapid access and improve overall quality of care among our IBD patients. Next slide. And this has resulted in really what's going to become a flagship publication from the IBD group. It was just published in the February issue of the World Journal of Gastroenterology, and it goes into all of the details and metrics related to our rapid access clinic at the McGill IBD Clinic. Next slide. And well, what is the impact of the COVID pandemic? And I think we're well aware of all of the socioeconomic ramifications, the physical ramifications, and and the high mortality and morbidity associated with COVID. And the psychological ones are really hitting us individually and collectively as a society. And if we look at the psychological impact of COVID, fear and anxiety is a normal response to a threat that's characterized by imminent danger and uncertainty. It's very present focused, and the reaction is to focus on what we can control. What we're trying to avoid is the spiraling and worrying and rumination that's future directed, because that's an unhelpful response and it leads to hopelessness and more anxiety. Imagining, well, what if Disney doesn't open in August when I want to take my kids down to Disney? What if the stock market does this? So there's a lot of the what if is something that we try and avoid spiraling. Next slide, please. So I'd like to introduce you to a little bit of science in terms of providing us with some of the underpinnings regarding how stress affects IBD. The growing and emerging paradigm concerning the conversation between the brain, the central nervous system, and the gut. Within the gut is a very rich, analogous nervous system. It's called the enteric nervous system. And there's a dialogue between the gut, the enteric nervous system, and the central nervous system. Over 90% of the chemicals that are responsible for our thoughts, feelings, behaviors, and that are found within the brain are similarly found within the enteric nervous system in the gut. And sandwiched between the brain and the gut are a set of bacteria that are collectively known as the microbiota or the microbiome. And this microbiome actually modulates and sometimes referees the crosstalk between the brain and the gut. So you can imagine if there's a perceived threat or stressful event occurring, it will impact on the gut, it'll make it leaky. Bacteria that are present in the gut gain purchase to the cells that are just beneath that layer of cells that we call the epithelium that's responsible for the absorption of our nutrients. And by stimulating inflammation, that's where the pathway of uncontrolled inflammation begins. Now, that's how this direction occurs from the brain to the gut. But many of these products, these inflammatory molecules that are made by the gut, can get into the circulation, and they can they cross the blood-brain barrier, and they can alter thinking and affect. So they affect thought and mood. So this is really this whole, so I've taken you through for a little dip in the pool of science, but this is really important because not only has it given us the signpost for targeted therapy for inflammatory bowel disease, but really is giving us a framework to begin to understand how stress affects the gut. Next slide. So a couple of weeks ago, when this whole COVID crisis was evolving, I'm a fan of observing human behavior, specifically among my colleagues. I love my colleagues. It's like going to a museum every day, interacting with them every day. And I was looking at behaviors of my colleagues, other healthcare workers, and trying to come up with some cartoon view of stress and coping and how some people are more resilient and they're coping a little bit better. So I sketched it out in a sort of storyboard way. And if we look at the COVID-19 health crisis, yes, it's very, very complex. The science of it is complex, the epidemiology, the impact, very complex. It's characterized by multiple unknowns. It's the biggest threat that I've seen in my personal life and in my professional career. Above all, it's unpredictable. And when I look at healthcare workers, and really we can extrapolate this. Everybody in their life is at the front line of something. You are the front line of defense and protection, whether it's for yourself, your family, your colleagues, etc. You have your own set of fears of exposure or of getting things wrong, of not doing things the right way. And you have a family to take care of, other people to take care of, and other people to worry about. Next line. And I think everybody has a way of finding the right balance with respect to care, work, activity, and connections. You know, the balance, if you look here, example for care, you want to find a balance between looking after and overindulging. Work versus overwork, active versus inactive, connected versus disconnected. And in looking at my coworkers in the first couple of weeks, things I was seeing was, you know, really the important messages of taking care of yourself. You need to decompress, find ways to move, connect, rest, go for a walk, and above all, connect with your values. Next slide. Just the one above it.
Yeah, here, right?
There you go, perfect.
Yeah, okay, sorry.
And in noticing people's behaviors in the first sort of few weeks of the pandemic, there are essentially two different coping postures that were really sort of quite obvious. There are those who are really good problem solvers, and we call this problem-focused coping. People who look for practical solutions, trying things out, different strategies, being in a state of preparedness. And this, we were getting together with our Zoom meetings, and the whole goal here was let's make a plan. And you saw other individuals where their primary posture was more towards an emotion-focused coping stance. And a lot of people were feeling helpless, wary, the constant what if, what's going to happen, a lot of anger. And I think at the end of the day, it's important to acknowledge our feelings and not bottle them up, and to be compassionate and to really accept that we're doing our best. And breathe. Breathing in calms your body, breathe out, calm your mind. It can become a mantra. Next slide, please. And with any sort of catastrophe that goes on, you see tremendous human resilience. And there are multiple definitions for resilience. And the one I like is the one by Walsh, that resilience is the ability to withstand and rebound from adversity. And we could look at individual resilience, and that is you acknowledge, know your own strengths, and build upon your own strengths. But we're seeing with the pandemic is relational resilience, and that we're drawing strengths from others. And it's quite interesting that if you look at crises, most stresses and crises, they challenge us, but they don't necessarily damage us irreversibly. If you look at major catastrophes, about a third of individuals are probably changed and damaged irreversibly. Another third will get back to the pre-catastrophe crisis state, and another third actually thrive and grow from having experienced the catastrophe. And I sort of made some summary points on how to keep on keeping on. It's to be flexible, to respect individual needs, to respect differences, boundaries, etc., to remain connected, and keep in touch with your values. And remember, there's a whole world out there and that we're part of it. And communication, as we're doing this evening, is really central to building resilience, as well as resting appropriately and seeking help when needed. Next slide. Some of the key messages with respect to how to help individuals navigate the stresses of stress, whether it's stress and IBD, is that there's really a very short supply of quality evidence for IBD-specific psychotherapies. And there are very few studies on psychopharmacology and IBD. And yes, we know a lot about disease activity, the natural history, treatment, et cetera, but in the absence of robust data for efficacy of IBD-specific psychotherapies, we have to extrapolate from evidence derived from non-IBD patient populations. And in my survey of the literature and in connecting with patients, one of the areas that holds the greatest promise, there are really sort of two avenues approach. One is the novel, and this was novel from about 2010, and it's now termed acceptance and commitment therapy. And there are various online and digital forms of this. And this is becoming really a key psychological intervention to help people with chronic diseases as they navigate psychological stresses and adversity. Next slide, please. So I drew from the basic and core principles of acceptance and commitment therapy and devised, and this the two champions of this, the science behind this, are Russ Harris and Steve Hayes. And I drew from the basic tenets of ACT and came up with an acronym called FACE COVID, where each of the letters stands for some element, and where F is focus on what's in your control, A is for acknowledge your thoughts and feelings, C, come back into your body, E for engage in what you're doing, C, committed action, O, opening up, V, your values, I for identify resources, and D, and the most important one is disinfect and distance. So I want to go through each of the elements and then we'll open it up for discussion. Next slide, please. So focus on what's in your control. In your control, I think we're faced with that dilemma of what's going on in our inner world, our thoughts and feelings, versus the outer world, the problems that are related to the pandemic. We all accept that we can't control COVID. We can't control the agenda of the virus, nor can we control our thoughts and feelings. And I think the best analogy is imagine you're a boat at a harbor, docked, and there's a storm. If you don't do anything, you can be sure you will be swept away with the storm. And to focus on what's in your control is analogous to dropping anchor as the storm passes. So although we can't control our thoughts and feelings, we can take control of our behavior to respond effectively to the crisis. Next slide. Acknowledging our thoughts and feelings, what I mean by that is to silently and kindly, non-judgmentally, notice whatever is showing up inside you, your thoughts, your feelings, your memories, your emotions, your sensations, and take on the role of being a curious scientist. I am noticing anxiety. I feel sad. I have thoughts of getting sick. I have thoughts of having a relapse of my Crohn's disease or ulcerative colitis. Next slide. And as we notice our thoughts and feelings, the next step is to come back into your body. And you start connecting with your body by simply moving it, because by moving your body, you're acknowledging that you are now focusing on what you can control. Breathe in and breathe out. And I look at breathing in as just a way of reciting breathe in, the here, breathe out, the now. So it just reinforces to being present in the here and now. Stretch, straighten your back and spine, keep your feet on the floor, bring your fingers to your palms. And this is a way of physically moving your body and connecting. And it's the mindfulness of being connected in the moment. And I think everybody has some mantra or some analogy. When I do this a couple of times a day, my mantra is to let the snow melt on the radiator, but whatever works for you. Next slide. And is there a science to this, or is this just hocus pocus, etc.? Yes, there is a great emerging, robust science behind the neurobiology of fear and anxiety. And this shows a functional MRI of the brain and the different areas that light up. in different forms of anxiety, whether it's social anxiety, fear, post-traumatic stress disorder, social phobias. Next slide.
I also, sorry, we just got a comment on the chat. If everyone can please mute, except for Dr. Wild, because some people are not muted. But maybe, Dr. Wild, can you do that? Except for me?
Can I do that?
Yes, you can. You can mute everyone else. You are in control.
You're in control.
No, you're in control. I'm not.
You, Gary.
Yeah, when I press mute, it's
Joyce, I see. Yeah.
The little arrow,
yeah.
the little
There we
arrow,
go.
and then you can mute everyone.
Thank you. Only because I think it's scratchy for some people.
Yeah,
Thank
okay.
you.
No problem.
Okay, I'll go to the next slide now.
Next slide. And this shows, this is a functional MRI from comparing controls and individuals who have undergone mindfulness-based stress reduction programs, showing that there's really differences in perfusion of the brain in areas that are associated with anxiety and fear before and after going through sort of a paradigm of mindfulness-based reduction. And this is really an emerging science, the same as whether it's mindfulness or meditation, you see the same sort of science. Next slide, please. The E for engage is engage in what you're doing. Get a sense of where you are and refocus your attention on what you're doing. Just take a break and notice 3 things that you can see in the room, 3 things you can hear. Notice tastes and smells. The whole point is to notice what you're doing. Next slide. And by committed action is effective action that is guided by our core values. And it's effective action, and even if it means doing some of the heavy lifting, and even if it brings up difficult thoughts and feelings when you engage in that action, ask yourself simple and realistic ways to care and nurture for yourself and those that you live with. Committed action in the form of kind and caring supportive actions. Reach out to the people within your orbit, be it phone calls and texts. Phone calls are becoming a dying art, and it's something that's worth revisiting, particularly in a time of crisis. And make effective use of your time in isolation. Explore healthy eating instead of dominoes and binge eating. Exercise, and I'll go into that in a little bit more detail. Hobbies, and one that is extremely effective in navigating sort of ongoing adversity in character is a phenomenon known as gratitude journaling. And there's a very good science behind it, looking at wellness parameters as target outcomes. Gratitude journaling is simply writing down at the end of the day 3 good things that happened. Could be something as simple: had a great Caesar salad, talk with Peter today. Simple things that you just at the end of the day. And it's interesting that both in the short term and in the long term, and if you continue with it, the data is as far out as 2 years with respect to its impact on overall wellness, happiness, etc. And a lot of this was championed by Marty Seligman, who is at University of Pennsylvania, and is probably one of the co-fathers of cognitive behavioral therapy. And there's really an interesting science behind that. Next slide, please. Opening up, make room for difficult feelings and being kind to yourself. Self-kindness is essential and core to coping with crisis. And ask yourself the question, if someone I loved was going through this experience and feeling what I am feeling, if I wanted to be kind and caring towards them, how would I treat them? How would I behave towards them? What might I say or do? And then try treating yourself in the same way. Use that as a paradigm for self-caring and self-kindness. Next slide. By values, I mean your committed actions should be guided by your core values. And I just listed a couple of them, core values. It was Chris Peterson who was really the behavioral scientist who came up with a whole, it's about 2 million people that have been surveyed, and there is an assessment tool called Values in Action and a website. And among the values that are listed are love, respect, humor, patience, kindness, etc. And ask yourself the question, what do you want to stand for in the face of this crisis? What a sort of person do you want to be as you go through this, and how do you want to treat yourself and others? Next slide. And I summarized it by saying, do something today that your future self will thank you for. Next slide. And I think we're all faced with the challenges of identifying resources. Identify resources for help, assistance, support, and advice. I see it on a day-to-day basis. Our nurses are outstanding as key resource people, helping people, our patients, navigate the complexities of living with Crohn's disease, whether it's active disease or inactive disease, reaching out because they're having trouble, whether it's getting prescriptions or related to sending your kids off to school, etc. So these are key resources. Also reach out to your social networks. And if you're able to offer support to others, let them know. And you can be a resource for other people just as they can be for you. Next slide. And the D is the one that I think we're hearing enough said: disinfect and distance physically. And the next slide. Disinfect and distance mentally. Limit your screen time, limit social media, and above all, limit contact with those whose stance is constant scare talk. Oh, I heard about this neighbor. Oh, what about this? I heard this, I heard that. Limit that, those sort of interactions. Not cut them out completely, limit them. Next slide. So this is the summary of Face COVID, the focus, the acknowledgement, getting back into your body, connecting with what you're doing, etc. Next slide. And some of the useful links I've come across, and I've sent off the slides to Emily, and we'll post them on the IBD website as well. Crohn's and Colitis Foundation of Canada have really provided a lot of very useful information about using your medications, which ones are safe, which ones are less safe, etc. And it's really a very useful go-to site that we're informing all of our patients about. The two mental health sites that I came across that I would highly recommend, there's the Canadian Addiction and Mental Health Center. They have a lot of very useful information on stress management in the context of COVID. And the Quebec homologue is equally extremely helpful. Next slide. And I just want to say a word about exercise. And as I really have the privilege of teaching a whole bunch of bright undergraduates. And if you just, Emily, if you could just click the link on Facebook.com events one, the one just below, no, just below, yeah, that one. It'll take you.
I'm not sure I could click that link actually.
Sure, you should be able to.
No, it's not clickable.
Okay, it's not clickable.
No, I'm sorry. I mean, I could go to my screen, but then I'm not sure how that works. Okay.
But if I challenged a group of my students, and they know that I see patients with IBD, et cetera, and I asked them to do a little bit of homework looking at the effects of exercise on IBD. And within a week, they set up, and we'll send you the links, a great Facebook site and a challenge to undertake a 7-day exercise program. And whether you have IBD or not, I follow it every day. And these very clever undergraduates have now about 350 followers that are following them every day. A lot of our IBD patients are following them as well. And we're putting together the metrics of sort of wellness, etc., before and after, and they're actually turning this into a very valuable research project. Next slide, please. Yeah, and the sort of rationale for this is that if you look at when we're in a sedentary state, when we start exercising, and particularly in IBD, we start turning on the synthesis of a whole bunch of molecules. The most important of them are known as myokines. And myokines are very potent molecules that have a key role in inhibiting inflammation. Certainly, there's a lot of experimental evidence for it, and there's very good data emerging in humans with IBD that exercise is beneficial. Not only do you feel better, but there's a very good scientific underpinnings to explore that. Next slide. And I'd like to extend profound gratitude to my co-workers, and I've listed all of the sort of workers that are out there. And I think we owe them a tremendous, tremendous amount of gratitude for the work they're doing on a day-to-day basis, and an equal gratitude for the people who are staying home, because by staying home, they're not out there risking themselves and risking others as well. So I think we're all heroes in all of this. And in closing, I'd like to just take a moment and really think there's one person I'd like to dedicate this to, and the memory of, that's certainly Seidman. And I think we all acknowledge with tremendous gratitude his commitment and his courage that he showed to his patients, to his community, and to us as colleagues. So I'd like to dedicate this talk to Ernie.
Very nice. I was just thinking about him, and I'm sure he is happy this is taking place right now.
So without further ado, why don't we just open this up to questions?
So thank you very much, Gary. Everyone can send comments and also questions, just one by one. And if you would have a question to nurses, then I have seen that 2 of the nurses is online as well. So sometimes they could come back as well.
Should I stop sharing the screen, or do you still want to make
I think it's okay.
Yeah, you can stop sharing it, sure.
Okay, there we go.
Great, that's better. Now we can see the whole gallery.
I know that there was a question that was directed to me, but there we go. Samantha Maldoff, she put it on the chat for you.
Yeah, there we go. Here's a good question from Samantha. It says, I've been on Remicade since 2014. Does being on Remicade put you at higher risk for getting COVID in comparison to other IBD patients on other types of medication? Well, look, we know that the medications that don't put you at a particularly high risk are the non-absorbed steroids. Entocort is the main one, and all of the 5-ASA products don't confer any necessary greater risk. Yes, Remicade is a risk. It's a risk if you're on prednisone, but you've got to look at that you're keeping your disease under control, and disease activity as a risk is really a very, very important risk factor compared to the biologic. If you stop your biologic, that's when you can really get into trouble. And Peter?
Yeah, so what we know actually is, and there is now, if you look at the CCC, so the Canadian Crohn's and Colitis website, there is a pyramid that was assessing the risk, and it's a risk stratification map. We kind of went into that, but not over on the discussion yet. So I just repeat, it's actually including your age, comorbidities, so not necessarily only IBD related questions, the activity of the disease and the type of medication, as already Dr. White has said, immunosuppressive medications, especially high dose of steroids, together with a disease activity, or azathioprine Imuran, again, which is known to be risk for viral infections. They are thought to be a little bit more important. However, if you have, and this is the most important comment, your disease under control with a medication that doesn't affect the viral risk, meaning including the biologicals, especially the new ones that are not associated with, infectious risk like Stellara or Entyvio, these are kind of those medications, then probably you are much better off continuing the medication. Absolutely. And having your disease under control than to stop it and risk it. So once again, your age, other comorbidities, and the activity of the disease needing steroids, that's the most important risk. And then I did today about 15 online, consults with IBD patients. So I repeated that 15 times already today.
Yeah.
If you are, younger than 50, of course, you hear it that I do it all the time today. And not just today, I mean, the last couple of weeks.
Yeah.
And then once again, if you are younger than 60, no comorbidities, and you are, well controlled with your disease, then actually your risk is not worse than the general public according to the same age group, and you should follow the public health, recommendations, I guess. Gary, you are on.
Yeah, it says here, one of my concerns is around continuity of care during this time of COVID, while our hospitals are focused on urgent care. I think for us at the MUHC with the IBD clinic, continuity of care is something that has happened on a day-to-day basis, and it was simple to ramp up and provide that continuity of care. The only thing that has changed is we're doing more telemedicine and telephone visits than face-to-face visits. But I don't think anybody is unduly ending up in an emergency room, etc., or we're seeing major flare-ups of disease because of lack of continuity of care. The nursing support and access to physicians, be it email, telephone, telemedicine, truly has been outstanding. And it's something that we're documenting and keeping really a very careful audit of. So I don't see that as being necessarily a tremendous problem. In those individuals who are experiencing a major flare of activity and require emergency services, we have 24/7 coverage where they're seen by the attending staff with or without a GI fellow. And really there's great continuity of care from that respect.
So I just would like to add that, usually like the physician who is either, doing a virtual clinic or, having like in-hospital service who triage, all those emails that you send to us regarding either, questions regarding medications or risk or flare or actually staying home. We have quite a bit of those requests, about, what to do now that, of course, the schools will reopen. Shall I stay home, or what's in this context, the real decision? And Kelly, one of our nurses actually, so I will ask her, is on the group, and she could tell what's the average number of the emails that we receive on a day-to-day practice, but it's, it's a large number. So I have to be honest, after sorting out, we see maybe three or four patients, like, on a daily type of basis to triage whether we need to see them or just come back with a virtual or, email, consultation. And some patients, of course, we see in person. But Kelly is there. Kelly, if you can
Kelly,
unmute yourself, you can comment.
So in terms of patients that we see physically in the clinic, we see maybe about 2 a day maximum on average. And I think the patients are afraid of coming in and they like this teleconsultation. They feel comfortable with this. And I think we have about maybe on average I would say about 75 emails a day, plus maybe 20 voicemails a day. So that it's about 100.
Thank you for only making me triage about, up to 10 per day. That's good.
That's what we're here for.
Exactly.
Yeah, exactly.
And the platforms we're using, I use Zoom, I use telephone, and I use React, which is the provincial sponsored telemedicine platforms, and they're working extremely well. The React platform is very good because we can see the patient file at the same time as we're seeing the patient, and we can split screen and go over lab values, x-rays, etc. with the patient. And it's really, I think, beyond the pandemic, it's going to become incorporated into our ongoing care of IBD patients. Let me see here. It says here, can anyone access the clinic? Do patients need a referral? How can people get access? That's a good question. We see everybody. We're getting tremendous numbers of referrals. Another question, do you think telemedicine will remain after the crisis is over? Yeah, absolutely. I think it's going to become a very useful ancillary tool for patient management. Yeah.
Gary, what percentage do you think you will stay virtual compared to the face-to-face visit? Just a hint.
I did a guesstimate. I've been keeping the metrics in my practice, and I would put it as a 50-50 split at the present time. And it's something that would be very useful to explore as an ongoing collaborative research project, is that we have a start point as to when we started with the telemedicine, and we can look at, people fluxing in a state of flux, going back and forth to it, some people preferring telemedicine. There's a tremendous convenience, for those who have tried parking at the Montreal General Hospital. That can be as complex as the COVID crisis. Yeah.
Okay, so just a little more, scientific details. I don't know how many of the group has heard, but there is an IBD specific registry as well in regards to COVID. It's called Secure IBD. So if you're really interested in seeing the IBD related, COVID reality, of course, that is a selection bias, meaning that some of the patients get in, some of the patients definitely are not reported. Personally, we cannot report, just to give you a little note on that, because we don't have still the approval by the ethical board from McGill. But you see globally, a couple of hundred IBD patients, and the profiles that they were doing good or bad with COVID. So you can search as well. There is a link from the CCC website as well. But if you look for Secure IBD, that's actually kept up to date with one of my friends, who is Gil Kaplan from the University of Calgary. So it's really searchable. It's a nice tool. It's a nice tool to see the IBD related questions if you're interested.
I have a good question here. I have had a colonoscopy postponed, which was booked for April. When will scoping resume? That still is a moving target. We are prioritizing what are called P1s, and a lot of them have been patients with cancer or high index of suspicion for cancer, where we know that the colonoscopy is very important for mapping and for purposes, diagnostic purposes, biopsy, and then subsequent operation. We have similar P1 or high-level criteria for upper GI endoscopy as well. But we are meeting on a weekly basis. We meet with the ministry. We meet with the Quebec Association of Gastroenterology representatives, as well as hospital managers, to plan a stepwise rollout of activities where the guiding principle is patient safety. So nobody will fall through the cracks. We are constantly revisiting our waiting lists to make sure, and contacting patients to make sure that that no delay is goes beyond what are reasonable expectations right now.
A little note. I'm at the moment on the service, so I'm doing this on-call type of active patient. And then just to let you know, today I have scoped actually 2 IBD patients because of being really active. One of it was a new diagnosis. The other one was unfortunately really active disease. So that means that if you have a colonoscopy delayed, you're lucky enough not to have really an emergency situation. That's already good, okay, to start with, because actually if you have really severely active disease, you will be scoped, but hopefully you don't need it. As for the opening, we actually expect honestly and realistically to get the usual IBD active patients, that are not very emergent active patients, to be able to put on the list as of end of May, early June. Of course, the problem will be, as you can expect, isolation, because even in the waiting room, you have to isolate, you have to wear a mask. So that's actually, and the patient turnaround is the main issue with the colonoscopies. For upper GI, it's even more a problem, because then during the procedure the virus can spread, so that's even more technically more demanding to do now a gastroscopy compared to a colonoscopy.
Very good question here. Now that things are opening up, should someone on Humira or any other medication be concerned and still stay at home and work from home? That's becoming the most common question that we're seeing. And I think the whole opening up concept that we're seeing in the United States and the brutal reality that we're seeing is, yes, we acknowledge that with opening up, there will be more deaths. And the economists are looking at models of, how much our morbidity are we prepared to tolerate in lieu of opening up and trying to return to some new normal state. And I think individuals who are on a biologic, if you can still work from home for a reasonable time frame, etc., it's something that obviously, if you can do it, go ahead and do it. But these are very real questions that we're all facing. We have parents who are having inflammatory bowel disease. They have young school-age children, and they're concerned that if they send their kids to daycare centers or to primary school, etc., those children will come home and the parent is an immunocompromised host. And yes, there is a risk. Can we assign an absolute number to that risk? No, but we must appreciate that it is a risk, and any risk, if avoidable, should be considered, and you should take the necessary action. Peter, do you have any comments about that?
Yeah, as Dr. White didn't tell it, but actually just this week we had a discussion, a group discussion, around that exact same question. The nurses highlighted this as a problem, now that the schools are actually opening up, and we had actually suggested the following. First of all, the IBD is not the majority of the population, still a relatively rare disease. So why should we risk actually those who have high level medications, and they are still a minority, if they have really concerns? And so far everyone was pouring on them the information how difficult and dangerous this pandemic is. So you cannot just wash off this label, I think, in one day. So to be honest, we discussed and agreed that all those patients who are either have really active disease or have any risk factors and plus on biologics, and even if they are actually well controlled, they can email us for these requests to continue the suggestion from working home. So we have developed a standard formulary for that suggestion, and we actually distributed till early June, and we will reassess, of course, the situation early June, how it's again changing or evolving with the public, in line with the public health recommendations.
That's something it's been deeply appreciated by our patients, because besides the uncertainty of COVID as a disease and being on medications, etc., the whole uncertainties related to work has been really, if you survey our patients, and I ask them, what are your top concerns? And among the top 3 concerns are work related. And the nurses have been really profoundly helpful in helping our patients navigate some of these issues related to schooling, work, etc., etc. And this has been a tremendous support benefit to our patients. And I really appreciate the collegiality of all of us coming together and facing this. We're great at disagreeing on everything. We have opinions about medications, etc., and we're very talented in that. But yet we could use that talent to come together for benefit of our patients, to come up with these work forms and come up with really standard operating procedures to really make this as easy as possible for patients. Yeah. There are questions related to, will the video be on the website? Yes. The PowerPoint as well.
Although I think there's a way that I can actually share the PowerPoint right here with everyone. Can I try?
Yeah, go ahead and try it. Sure.
Let's see. If not, it will be on our website as well.
Yeah, absolutely.
But I just, I think it's loading right here. This is amazing.
Yeah. Some minor glitch on my computer. I can get it to work now, but it's, yeah.
There, it looks like it loaded.
Yeah, it did.
Okay, great. Good. But I was answering in the chat. This entire Zoom presentation will be posted on our website. I just have to actually, yes, I will do that, and I will let everyone know when it's up, I can send everyone an email again, and I will also tell everyone on Facebook that it's now on our website.
Emily, can you tell everyone what the website is in case they don't know?
It's also in the chat. So the website is mcgillibd.ca. It has all the contact information about all the doctors, all the clinics, the research team, the nurses, every individual line. It also, I've been working hard on the all the clinical trials that are up there, as well as all the academic research that all the doctors are involved in, looking to participate in studies and different, everything is up there. So I encourage you to take a look at those pages. And it also has a lot of information about our fundraising and our annual events, which we will be having to probably come up with some creative virtual fundraiser this year. So stay tuned for that. But we do rely on everyone's support to have the group and all our amazing care from the entire team running. And it's all because of the supporters such as yourselves and others. Yeah.
Totally agree. Another question, for those on Remicade, should we take extra caution or extra measures around the time of infusion? There are tremendous precautions already in place in the standard operating procedures that are underway in the infusion centers themselves. I think the precautions you have to take is, how do you get there? Are you going to take public transport, hand washing, all of the things that are within your control, because those that are within the control of the infusion center are really done in an outstanding fashion with safety in mind.
So Gary, again, the IOIBD and the, task force for the COVID for the Canadian, IBD group and the Canadian Gastroenterology Associated, they developed let's say a checklist for, the IBD infusion centers. So it is standardized at the moment, just to let you know, so everywhere around the country, you should have the same, standard operating procedures. Everyone agreed, actually all the providers agreed as well. Again, you can read that on the IOIBD or the CCC website as well. So these are actually now standardized. And just one short note back, because I think, the off work and the schooling thing is also very important. So I just share with you one little data from the literature. In France, actually, there were some outbreaks in schools, and they wanted to get a grip, or how much infectious it is in the children, and how much they actually transmit the COVID. And I get you good numbers, or actually worrisome numbers, because the transmission was very low. So first of all, the children actually they had a very mild symptoms, if at all, and all those schools who had this outbreak. Watch out, they had about 10% who became positive for serology. That means that even in an outbreak situation, the children were not very good transmitting and also getting the virus, which is for the protection. But it's also telling you that if you have small children who go to school, they are not at very high risk. And also, if you finally decide to let them go to school, probably they will not get the virus back home. However, of course, this is still, a big concern. I agree.
Yeah, absolutely. This is an important thing. And from that data set came the fact that some of these kids have tremendous atypical presentations of erythema of the toes and fingers with some skin breakdown. And parents have been monitoring for this fastidiously, and they have been picked up as very early infected carriers, etc. And it's quite interesting that that sort of natural ecological experiment, we've been able to have a very reliable, robust physical sign of the kid who's infected or not.
Gary, if I may add two more small puzzles, because I think that's very important for the patients to know. So there has been now, enough data around that. Yes, COVID can present as a GI only symptomatic. Okay, so you can have only diarrhea, and as you have heard, also sometimes just some skin rash as a presentation. But most of the gastroenteritis is still not COVID related, and only 3% of the diarrhea associated with COVID presents as diarrhea only. So 97% of the patients who have COVID, they don't present with GI only symptoms. So in other words, if you are having a concern that you have COVID because of having the diarrhea, don't think that. Most of the time it will be still either your IBD or your some other viruses, gastroenteritis viruses. And there was a question about the pregnant woman. So for those, I actually have a very good news. So it seems that for a pregnant woman or somebody with small children who are having breastfeeding age, they are protected. We don't know and we don't understand very well why they are protected. But yeah, exactly. But it seems that they are very, very difficult to be infected with COVID. And even if the very low numbers that they had either no symptoms or very mild disease. So this is what I told, because I did the other day I had two young female Crohn's disease patients who presented and said, Peter, I have pregnancy. What do I do now? And I said, you know what? Best time to become pregnant. Sorry for the joke, but you are protected. For the COVID, definitely, that seems to be an advantage.
So here's the question: if a woman is pregnant and she's say 20 weeks pregnant and just experiencing a culture negative flare-up of disease and requires steroids, how does that balance out? You've got the protective effect of the pregnancy, and yet you're trying to introduce steroids for management of disease activity. That we're seeing quite a few patients like that as well. And what are your thoughts on that, Peter?
Look, you have to do what you have to do. Basically, those patients, have to separate themselves as much as possible. I think so. There, the social distancing and isolation is key. But however, we know very well that the outcome of the pregnancy, most important, factor is disease activity. So basically, we really have to, get a control over the disease activity, get the patient safe. That's simultaneously the number one goal. I wouldn't say number two, it's number one. That means that, they have to self-isolate. And once again, we very much hope that they don't get the COVID, but even if they would have it, just to let you know, most of those cases ended up to be recovering without, actually any complication or symptoms.
Absolutely. There's a good question here. How long does the prednisone that's given at the time of, say, a Remicade infusion affect your immune system? We know about the pharmacology. If you give an intravenous dose of prednisone or say Solu-Cortef, the usual dosing is sort of every couple of hours. So in a couple of hours, pharmacologically, it will be out of your body. But the biology of it affecting your immune system is more of a question mark. It certainly is not of the order of taking prednisone daily by mouth at a high dose, because there we're really mandated to try and decrease and stop the steroids as quickly as possible. But the pharmacology is very short-lived of an IV prednisone infusion at the time of, say, a Remicade infusion. But its biological sustained effect on the immune system is probably of the order of a couple of days. What advice do you give to healthcare workers with IBD in terms of protecting themselves at work? That's very similar to the careful hand washing, all of those necessary protocols that a non-IBD healthcare worker would also take on. And I have in my practice a couple of physicians who have inflammatory bowel disease, and quite a few of them are doing different types of work other than direct patient care because they can. Some of the others are still seeing patients despite being on biologics and taking all the necessary precaution. So it's really, it's the interplay of informed decision making, benefit risk, and really taking into account a lot of that information. Peter, what are your thoughts on that?
Yeah, I mean, all what you said is true. But once again, if we're talking about special patient groups for the work perspective, then I would say like elderly homes, or then the school. And definitely, healthcare workers are, the top three, at risk, so to say, populations. Definitely, the elderly home, if there is one patient with COVID, it will spread. We know that. We have seen those, outbreaks now in the elderly homes around Montreal. Montreal is actually a relatively affected area, the highest rate in Quebec, in fact. And this is why actually, if you work really like, emerge or ICU, I think honestly that's not the best. That's not the best, choice to actually be really in the front line. However, if you can do a little bit of back office type of work and being less, affected with the, really the very active patients, then I don't see anything against. Once again, what I see emerge, ICU, and probably elderly homes, that's really a no-go.
Emily?
I mean, not all IBD patients. Definitely, if you are well controlled and only on 5-ASA, that's okay. But if you are, has higher level of medication, immunosuppression, or biologicals, then you should have precautions. Yeah.
Emily, do you have any comments?
Just that, thank you very much. If are we okay to? I don't think there's any more
I
questions.
don't see any other. Oh, here's a good one. Here's a very good one here.
That's a good one, yeah.
Yeah, if my spouse has active Crohn's, is on prednisone and Humira, can I go back to work? Again, one of the most common questions we're facing. It's certainly a risk factor, active disease, so we're looking at disease activity, presumably no other comorbidities, is on prednisone and Humira, can I go back to work? It's a case of the person venturing into an ecosystem of potential exposure and then bringing that back and potentially exposing an individual who is an immunocompromised host, even recognizing all of the appropriate distancing, washing, disinfection, etc. The risk is still there. And again, it's an informed decision as to how much do you really want to take that risk? And that's the question that we are facing as we're evolving into sort of, more and more of opening up of society. Yeah.
To be honest, Gary, it depends, because if you're working in an environment with very, very little contact with other people, probably then that risk is not very high. As in contrast, if you're working once again, in healthcare or any high contact risk with other people, then probably this risk is very real. And also there is another factor that I always joke around with the patients. If you want to self-isolate and you have a 2-story building and your spouse will be in the basement, or I'm sorry, not getting into the details where you want to have your spouse, then of course it's good, but you have to really isolate, and that's not very practical, to be honest.
Yeah, absolutely. But on the other hand, I think we have to be very good detectives with all of these sort of questions. I was asked that question. I said to the patient, "How do you get to work?" He says, "Well, I take public transport." And I said, "Okay, what do you do when you?" "Oh, well, I get off at the metro station. I try and pick up some groceries, etc., etc." So when you look at the detective epidemiology of that, it's not the same as going to a car and say maybe working in a workstation or whatever, and the person lives in a high rise and there's about 300 people in the building all using the same elevator, etc. So yeah, it's some of the questions, some of the things are straightforward, but some of the details add different little layers of complexity to the narrative. Yeah. So I don't think there's one size fits all answer, and that it's a question we're going to be seeing over and over again. Yeah.
Just want to ask the answer. There's one more question from Cindy also that might be relevant for people.
Sure. It's said that the immune system is in overdrive when someone is reacting badly to having COVID. Does being on a drug like Humira suppress the immune system? The immune system is overactive in inflammatory bowel disease, and what we're trying to do is modulate it and modify it to prevent tissue destruction. And there are some elements of COVID in the inflammatory response that actually requires TNF alpha. And some of the medications that are being used, like if you're on an anti-TNF and you happen to have COVID, obviously you want to stop that biologic because you want the TNF that's going to be recruited to try and get rid of the virus, kill the virus, etc. You want to have that available to carry out its job. So it says, does being on a drug like Humira suppress the immune system some? I'm not a fan of the term suppressing the immune system. I'm more of a fan of the term modifying the immune system, depending upon what the job it has to do in that moment. Peter, any thoughts?
I actually agree. I always say it's an immunomodulator, not an immunosuppressor, like azathioprine, the Imuran, or the steroids, the prednisone especially. They are really immunosuppressant. That's a different, mechanism of action. Tofacitinib would be somewhere in between because it's also very broad spectrum. So that's a question. As for Entocort, because that's, I guess, the next and almost the last point. This is a topical steroid. The first pass effect is very, very high. That means that they absorb locally, they act and in the bowel, and then they are absorbed by the liver by the first pass. 95% of basically the systemic immunosuppression is not there for this medication, or very little. So that's actually better. It's I always sell it as a modified steroid. You will have much less side effects, but probably similar efficacy in the bowel. So having said that, that's still actually a steroid but modified, much less risk for having problems with COVID than if you would have the original conventional steroid.
Absolutely. No other questions?
Multivitamins. Do you want to just tackle the last?
Multivitamins. There's really, outside of vitamin B12 as a documented deficiency, vitamin D levels are low in the province of Quebec, maybe in some of our patients a bit lower, vitamin D. There is no harm in multivitamins and no harm in probiotics. Are there any particular benefits? The answer is we don't know. And also in terms of support groups, yes, there are multiple support groups. You can reach out to our nurses. They have many, many pieces of information that they can either email you. You can reach out to other patients. You can reach out to the Crohn's and Colitis Foundation chapter in Quebec. There are multiple levels of support. There are the websites as well. Crohn's Colitis Foundation of Canada, US, in both languages.
Okay, I think it's a good time to wrap up. I just want to thank everyone again for coming on, and our website is mcgillibd.ca. If anyone has questions, you can email info@mcgillibd.ca. All the information's on the email that I sent out today. We're hopefully going to do another Zoom session like this at some point. We come up with topics based on, doctor, nurse, the team, what they think is valuable, but you can always email us, and I'm sure there's some similar trends. And I also just want to ask if maybe Lauren Mayers, who's the president of our committee, wants to say something just in our parting.
I just wanted to thank Dr. Wild for putting this together, and Dr. Lakatos for actually stepping into big shoes to be the head of our group. And we're glad that everyone joined us. As part of our mission is to help educate people, to be there to support, families, people with IBD. So this is great. It's more fun when we can be in an auditorium all together, but that will be sometime in the future, hopefully not too long. And actually, Emily talked about our virtual fundraiser. I might say that I'm more of an optimist than my friend Emily, and I haven't written off an actual fundraiser where we're all together. However, we don't know what's going to be, right? So you'll get more news about that probably in the near future. And next time, let's hope we have even more people on here, because I learned a lot tonight. It's amazing to have such dedicated professionals like we have in our group that make living with this, disease so much easier. So again, thank you, Gary and Peter. It really, it's great to have you. You have a hard enough time all day long, and then, to come and share this with us is really greatly appreciated.
Yes, thank you so
You're
much.
welcome, and be well and be safe.
Thanks, everyone.
Thank you.
Take care.
Thank you
Bye-bye.
very much, everybody.
Bye.
Bye-bye.
Bye.
Thanks.
Bye.
That was great.